Between November and March in the United States, pediatric emergency departments reliably fill with infants under 24 months old, presenting with worsening respiratory distress. This seasonal surge is driven by a viral respiratory tract infection called bronchiolitis. At the microscopic level, the Respiratory Syncytial Virus, or RSV, rapidly multiplies and attaches to the epithelial cells lining the vulnerable infant respiratory tract. While RSV drives the majority of these infections, parainfluenza and adenoviruses are responsible for a smaller subset of cases. As the virus takes hold, clinicians observe a classic cluster of lower respiratory symptoms: wheezing, severe rapid breathing, expiratory grunting, nasal flaring, and deep intercostal retractions. This specific presentation heavily mimics acute asthma. Because the outward physical signs are nearly identical, the initial clinical reflex is often to treat the infant using the standard asthmatic playbook. That playbook typically involves ordering chest X-rays and lab work to confirm the diagnosis, followed by immediate pharmacological interventions like corticosteroids or bronchodilators, such as albuterol. However, the American Academy of Pediatrics explicitly recommends against all of those standard interventions for bronchiolitis. Effective management of this disease requires discarding asthma-based protocols entirely. Instead, clinicians must rely on a strict framework of physical triage and targeted mechanical support. To understand why standard asthmatic treatments fail here, we have to look past the outward symptoms and examine the microscopic anatomy of the infant airway. This diagram compares a healthy infant bronchiole with one infected by RSV. The initial viral invasion triggers acute, localized inflammation. As tissue reacts, edema develops. The infected bronchial walls physically swell inward, narrowing the available space for air. Immediately following, the second phase of the immune response begins. Epithelial cells produce excessive amounts of thick mucus directly into the airway. Swollen tissues combined with thick mucus plugs create a total mechanical obstruction of the bronchial lumen. With the airway blocked, the infant experiences severe air trapping. Over time, trapped oxygen is absorbed but cannot be replaced, causing the affected lung segments to collapse, a condition known as atelectasis. Notice what is absent here. Unlike asthma, bronchiolitis involves zero smooth muscle bronchospasm. The airway muscles remain completely relaxed. Because there is no smooth muscle constriction to reverse, standard bronchodilators are entirely useless. The obstruction is a purely physical, fluid-based mechanical problem. Because the pathology is driven by physical inflammation and fluid, the diagnosis of bronchiolitis follows a predictable timeline. The illness typically begins with 1 to 3 days of mild upper respiratory symptoms, primarily presenting as standard nasal congestion and a mild cough. The clinical picture then shifts. Those cold-like symptoms deteriorate into severe lower respiratory distress, often accompanied by a mild fever. The primary objective indicator of this severe distress is tachypnea, rapid breathing exceeding a threshold of 60 to 70 breaths per minute. Once these physical signs are present, along with the seasonal history, the diagnostic criteria are met. The diagnosis of bronchiolitis must be made strictly through the patient's history and physical examination alone. Consequently, routine diagnostic testing is contraindicated. Clinicians are advised not to order imaging studies, routine lab work, or pulmonary function tests. There is a single exception. A chest X-ray may be considered only if a hospitalized infant actively fails to improve after standard treatment. Running extensive diagnostics on a standard presentation does not alter the treatment. It only exposes the infant to unjustified radiation, distress, and excessive medical costs. With the diagnosis established clinically, the immediate task shifts from identifying the disease to risk assessment and triage. Most cases are self-limiting, but clinicians must determine exactly who requires admission. This decision matrix outlines how clinicians aggressively screen demographic markers to separate standard outpatient cases from those requiring hospitalization. First, age and birth history. Infants under 12 weeks old or those with any history of prematurity are automatically flagged for the high-risk pathway. Next, clinicians screen for underlying comorbidities, chronic lung disease, congenital heart disease, or an immune deficiency syndrome significantly increases the likelihood of a severe course. Beyond background risks, specific physiological triggers dictate immediate hospitalization, including apnea with cyanosis or persistent intercostal retractions. Oxygenation requirements provide another hard boundary. If an infant requires supplemental oxygen to maintain SpO2 above 90%, they must be admitted. Finally, the matrix evaluates neurological and hydration status. Significant restlessness, lethargy, or an inability to maintain oral feedings are mandatory triggers. Strict adherence to these triage pathways ensures intervention occurs before the viral burden overwhelms the infant, preventing catastrophic respiratory failure in the most vulnerable pediatric cohorts. Once admitted, the treatment protocol centers entirely on supportive care. Because the airway obstruction is mucus-based, the primary intervention is mechanical airway clearance. This requires a strict suctioning protocol. Clinicians utilize continuous bulb suctioning of the nasal passages and upper airways, particularly before feedings and aerosol therapies. Environmental parameters are tightly controlled. Supplemental oxygen is initiated to maintain SpO2 above 90%, and the highly contagious infant is placed under strict contact and droplet isolation precautions. At this stage, pharmacological restraint is critical. Clinicians must not recommend corticosteroids to reduce inflammation and must not prescribe the antiviral drug ribavirin. Antibiotics are completely useless against the respiratory syncytial virus. They should only be introduced if a coexisting bacterial infection is independently confirmed through laboratory cultures. There is one nuanced exception regarding bronchodilators. While routine use is banned due to their ineffectiveness against mechanical obstruction, a brief trial of inhaled racemic epinephrine, or albuterol, may be considered, solely to provide temporary symptom relief or alleviate severe parental anxiety. This trial comes with a strict condition. The bronchodilator must be discontinued immediately if there is no objective, measurable evidence of clinical improvement. The overarching goal of treating bronchiolitis is not to cure the virus with pharmaceuticals. The true objective is to mechanically stabilize the airway and maintain hydration, giving the infant's immune system time to clear the infection. As the immune system gains the upper hand, the infant is monitored for specific clinical milestones indicating they are ready for hospital discharge. The primary respiratory milestone is a breathing rate that drops below 60 to 70 breaths per minute, accompanied by 0 physical signs of respiratory distress. The infant must also meet secondary metabolic milestones. Their oxygen saturation must hold steady above 91% on standard room air, and they must demonstrate the ability to stay adequately hydrated through regular oral feedings. Once discharged, the clinical focus moves to outpatient defense. Preventing reinfection or transmission requires comprehensive family education regarding environmental hygiene. Parents are instructed to strictly avoid exposing the infant to secondary smoke. They must also limit the infant's exposure to sick siblings and restrict time spent in high-infection settings, such as daycares, during peak viral seasons. This infographic summarizes the standard discharge criteria on top and introduces a specialized pharmacological prevention strategy on the bottom, reserved strictly for the highest-risk patients. That preventative measure is palivizumab, sold under the brand name Synagis. It is a targeted monoclonal antibody utilized specifically for RSV prophylaxis. However, there is a strict limitation on its administration. Palivizumab is recommended exclusively for the high-risk cohorts identified during initial triage, specifically premature infants or those living with chronic lung and congenital heart disease. Ultimately, successfully navigating the management of bronchiolitis is an exercise in strict clinical restraint. It demands trusting physical assessment over excessive diagnostic testing, prioritizing simple mechanical support over ineffective pharmacology, and deploying powerful prophylactic tools only where the data explicitly justifies their use.